name is Ray Massey, and I'm the Patient Engagement Program Manager for AST's Power to Save. And it is my absolute pleasure to introduce you to our presenters for today. First, we have Mr. David White. He is a kidney recipient, member of our Transplant Community Advisory Council, a fierce advocate, and maybe the fourth place winner in the 400 meter.
All right.
We also have Dr. Lisa Potter here. She is a transplant pharmacist at the University of Chicago and an AST board member. And last but not least, we have Michelle McCardle. She is a transplant financial coordinator at the University of Utah and a local executive director for the Transplant Games of America.
Thanks, Ray. Thanks for coming. We're proud of our athlete on stage. What we want to do during the next 40, 45 minutes is talk about the financial concerns that you need to think about when considering becoming a live donor or if you're a transplant recipient. So we hope that we'll be able to share perspectives from the provider side, both finance, pharmacy, as well as from the recipient side, as well as give some tips and resources both for donors as well as for recipients. Now, the menu of options that we could talk about is pretty vast and wouldn't fit into a short presentation. So we're going to highlight the things that we feel come up most frequently, specifically resources for live donors, how to navigate insurance changes, and then after you've got all of your insurance maximized, how to plug the gaps in terms of what might still remain as unaffordable. So to jump right into financial and tips support for live donors, I should mention that if you are considering live donation, a lot of the expenses related to your pre-donation evaluation and workup, your donation surgery itself and the hospital stay, as well as the post-donation follow-up appointments, all of those expenses are covered by the transplant recipient's insurance. So if you look at it from that perspective, it's not mandatory that you as a live donor have your own insurance, but it's strongly, strongly recommended. Why is that? Because we want you to be a healthy person in general. So that means you'll want to have your routine appointments with your primary care physicians. You'll need your routine screening, like colonoscopies, pap smears, mammographies. But also, occasionally during the donation workup, they may uncover health issues that you didn't realize you had, and you may want then to seek care and management for those. So health insurance for the donor, the expenses linked with the actual donation go to the recipient's insurance, but we recommend that you carry your own insurance. There are a lot of expenses, though, that lie outside of just the direct healthcare expenses. So for example, what about travel to the transplant program, lodging while you're there? What about childcare while you're gone? The American Society of Transplantation has put together a toolkit to help potential live donors think through all of these things and come up with a kind of a checklist to help you make sure you're not overlooking something. One of the introductory or first pieces in that toolkit is this cost estimation worksheet. So if you look at the top left, that's a box for you to think through what's your monthly take-home income. For living kidney donors, we recommend thinking through 2 months. For a live liver donor, we recommend thinking through 3 months. So write down what's your routine normal income and how might that be affected during the time when you might be out of work. Short-term disability, for example, doesn't often pay 100% of your income. It might only be 60 to 75%. So you'll want to think through how will your income change during that time that you're going through the donation and the post-donation recovery. On the bottom left, these are possible expenses linked with the donation. Again, think not only about just yourself, but also the support staff that might come with you. What kind of transportation, lodging, what are the expenses that might be incurred there so you don't get surprised by them at the last minute. On the top right, these are benefits that might be through your employer. So think through how many hours or days of paid time off do you have available to you? What kind of medical or sick leave does your employer offer? What are the terms for your short-term disability? Specifically, how many days do you have to wait before it would turn on, and how long would it last before it turns off again? And then in the bottom right, think through alternate sources of income, maybe grants, foundations, other support that might help you beyond just your own income. In the United States, you cannot get paid to donate an organ in the sense that payment can't be an incentive to donate, but you can make this balance sheet even. So you can work things out so that you're not disincentivized from donating. Most donors work, so you'll have to think through the time off from work. Generally, we plan 1 to 3 days of medical appointments for all of the testing to decide if you would be a donor, about 2 to 7 days for the actual donation surgery and the hospitalization afterwards, and then about 2 to 6 weeks of recovery time if it's kidney donation, and up to about 3 months of recovery if liver donor. Again, think through your work benefits, those that are paid, including paid time off, vacation days, medical sick leave. What are the terms for your short-term disability? Some things that people may not automatically think of are donated paid time off. Some employers will allow your colleagues to donate their vacation days to you, so that can be a nice way to enhance or beef up your own vacation days if needed. And some employers have specific living donor leave, which is paid leave above and beyond what might be in your medical or your vacation policies. There's also the option for unpaid leave, up to 12 weeks. This would apply to both you or your caregivers, so that your job is still there for you, even though you may not get paid if you're out for the FMLA benefit. And again, don't forget to budget for both yourself as the potential live donor, as well as any caregivers that will come with you. With regard to insurance, I talked a little bit before about who pays for what in terms of the donor workup and the donor health care. But this is thinking more long-term. Like, if you've donated a kidney in the past, will you run into a problem in the future with regard to health insurance? And so, by and large, no. Donation should not preclude you from insurance, and the Affordable Care Act says that it can't be, pre-existing conditions won't stand against you. It's similar for disability insurance. Being a live organ donor shouldn't stand in the way of you qualifying, continuing your base rates for disability. It can prompt a few additional questions and dialogue if you have disability insurance and then you're looking to enhance the benefit. But the real area where I want live donors to be aware of is this caveat for life insurance. A majority of donors will be able to buy life insurance, carry life insurance without the donation affecting it. However, some have run into a situation where they're either not able to buy a policy or they're able to buy a policy at increased premiums. As a best practice, what I would recommend is, if you're thinking about this pre-donation, enroll in an individual life insurance policy for yourself that's not linked with an employer, so that life insurance policy stays with you and carries with you through donation and after, so you don't have to have that sometimes awkward exchange of qualification after the donation. If you've already donated and now you don't have that and you're thinking of that and running into any trouble, be sure you include your live donor team. There may be some arguments that they can help you make with the insurance carriers to help them understand what's up with having been a live donor. And then finally, with regard to this, AFDT is the American Foundation for Donation and Transplant, and NKR is the National Kidney Registry. Those two organizations have some insurance benefits, both health and life insurance for live donors. So those can be networks that offer, that really understand and can offer benefits specifically for donors. An option that I love and want everybody to know about are the grants available to donors through the National Living Donor Assistance Center. If you qualify for these grants, these are $6,000 grants. In order to apply, you would contact the foundation directly. You can either apply over the phone or online. In order to qualify, it's an income-based qualification. So it's not your income that matters, it's the donor's income that matters. I'm sorry, the recipient's income that matters. So it has to be 300% of the federal poverty limit or less. 89% of those applications are approved. So, if you know that going in and you think that you're going to qualify based on the recipient's income, it often becomes a matter of just filing the paperwork and getting it set up for yourself. If approved, it comes to you in the form of an American Express card that you spend on your flights for up to 2 support people, your lodging, your meals, all of the expenses that aren't the direct medical expenses that come along with the donation. One last thing on this topic I want to mention are these federal and state laws about living donation. So federal employees have donor leave laws, which allows them up to 30 days of paid time off if you go to be an organ donor. The US Postal Service offers up to 14. There may be some additional state benefits that we can't recap, 50 different options there, but these websites will link you. Organdonor.gov is a site managed by the government, and kidney.org is a site managed by the National Kidney Foundation that can point you to what's unique or special about your state. Here's a snapshot from the organdonor.gov site, and if you look on the far right side, you can see, for example, that Arkansas has a tax benefit specific to organ donors. So if you didn't know that, you may not take advantage of it. There are public and then private leave of absence terms. If you double-click on the little green check, it will take you directly to your state-specific law or language so you can understand how to navigate and how to access that benefit. That's all I wanted to mention with regard to live donors. At this point, I want to turn over and talk about a recipient's perspective, and who better to do that than a recipient? So I'll turn it over to Dave.
Thank you very much, Lisa. I'm so glad there's a chair here because I just finished running a 400-meter race and I really need to sit down right now. So my name's Dave, and after 6 years of dialysis, on June 28, 2015, I received a kidney transplant from a deceased donor. And Hercules, my deceased donor kidney, and I are thriving. We're doing just great. But there's just one problem, and that's that today, August 5th, 2018, I do not have health insurance. And this happened because I forgot rule number 1 of being a patient advocate. And as Ray said in the opening remarks, I'm really passionate about advocacy. But rule number 1 about being a patient advocate is that you're always a patient first. And I just advocate so hard that I just kind of let this slide. That's the truth. I have no one to blame except myself. So I knew this day was coming. So a few weeks ago, I said, well, you know, my Medicare, which ends 3 years and 1 month post-kidney transplant, that date's coming up, so I better get my butt in gear and sign up on the marketplace for marketplace insurance. And that's what I did. I did that a few weeks ago. I went on the website, I picked out my plan, and I was approved, and they said, congratulations, you have healthcare insurance, and it will start on September 1st. And my jaw dropped. And my first 2 thoughts were, uh-oh. And my second thought immediately is, what am I going to do about my medications? Now, fortunately, it's not my first time around the block with medications because I was on dialysis for 6 years. So I knew to have some surplus medications at home. And it's even more important as a kidney transplant recipient because I need my immunosuppressants. So I have more than 1 month's surplus at home. So that'll get me through this month. But I also have hypertension, and so I take 3 different blood pressure medications. So what am I going to do about those without health insurance? I had no idea. Fortunately, I have a very good, what I now know they call an NP, but for 9 years I've been calling them nurse practitioners because I didn't know any better, silly me. But I have a great NP, and her name is Nancy. So I said, Nancy, what do I do? And she told me about this prescription service called GoodRx, which some people know about and some people don't. I'd never heard of it. GoodRx was founded in 2011 by a couple of former Facebook executives. And what they do is negotiate prescription contracts with pharmaceutical manufacturers and pharmacy benefit managers to negotiate low prices. So I went on their website and I typed in the meds I needed and the zip code, and if you've ever looked at Google Maps, it was basically a Google map with all the pharmacies in my area, with each of the prescriptions that I needed and the prices. And the prices are actually pretty reasonable because fortunately I can use generic immunosuppressants. So for my dosages for the next month at a minimum, I'll be paying about $50. And that's a pretty good bargain. And as it turns out, it's good that I learned about GoodRx because my new insurance, which starts September 1st, has got a really high deductible. And the GoodRx prices may even be better than what I get through my insurance. Now, it won't count against my deductible, but my deductible's so high that it really won't make any difference. So it's good that I learned this, and other people need to know about these things before they get like 6 weeks away from, their Medicare disenrollment like I did. So I'm here today to tell my story, and hopefully someone out here, maybe someone even here at the games will hear it and know not to wind up in my situation and take steps to change that. Lisa and I were talking last evening, and we said, it would be great if it was mandated, like for dialysis, they have certain things they have to do. It'd be great if the clinics were mandated, like 90 days before someone like me, you're disenrolled, if they just got in touch with you and made sure that you knew that you have to enroll, you have to really think ahead. Our healthcare system is really set up for dialysis. And that's a shame. It's really easy to be a dialysis patient. When I crashed in 2009, I was too sick to take care of myself. So my insurance was taken care of for me. I was automatically enrolled in Medicare, and my social worker automatically signed me up for Medigap insurance. Unfortunately, I had a nonprofit help me with my payments. So it was all taken care of for me. When I got my transplant, suddenly I was on my own. And even then, I knew that I'd have to continue paying for my Medigap, but I still didn't know the ins and outs of insurance like I should have. And it would be great if we all paid more attention to life after transplant, because it's not a cure. It is the best therapy right now, but there's a lot you have to do to take care of your kidney, both physically and mentally, like staying on top of things like your insurance. So in closing, it's ever since my transplant, it's been a really strange mix of emotions. I know that I'm alive thanks to science and thanks to research, but in the back of my head, that fear has always been there. What if? And that if is here right now, and I'm dealing with it. So once again, I'm here telling people my story today, so hopefully they can take steps and not have it happen to them. That's about it.
Thanks, Dave. And what Dave is going through now, having had a transplant in 2015, the eligibility for Medicare through the kidney transplant benefit is a 3-year benefit. So here it is, 2018, and here we are, managing that transition. Every transplant recipient will probably have to transition insurances because of job changes, becoming eligible or losing eligibility for Medicare, changes in income where you may become or lose your eligibility for Medicaid. So there are a lot of moments when you'll have to navigate this. In terms of doing that, I think it's important just to start from the beginning. So in the United States, there are 4 main buckets of insurance. There are the employer-based plans that might be through your employer or maybe your spouse's employer. There's the market-based insurance, which are plans you would enroll in directly through the healthcare.gov website. Those are the exchange plans. Third bucket are Medicaid plans. These are income-based eligibility plans offered by individual states. The criteria and the benefits vary from state to state, so it would be hard for us to give you a good idea here about what's available in all 50 states. So for that benefit, you would really want to work with someone who's an expert at the Medicaid benefit for your home state. And then the last bucket is Medicare. So there are 3 ways to qualify for Medicare. Either you're 65 or older, either you have end-stage renal disease, and that's defined as when you start dialysis, or when you're disabled. Now, the end-stage renal disease is when you start dialysis or retroactive to the first of the month when you got your kidney transplant. The third way to qualify for Medicare is through disability. Now, you can't just say, I can't work, I'm disabled, where's my Medicare? You have to be disabled according to Social Security's definition of disabled. So you have paperwork from your doc, Social Security has to endorse it, and you begin to get Social Security disability payments. That has to go on for 2 years before you become eligible for the Medicare benefit through disability. The waiting period is waived for patients with Lou Gehrig's disease, but otherwise that 2-year period is something that can sometimes get forgotten. Now, navigating in and out of employer-based plans, there's an unlimited number of employers in the US, so we couldn't give precise advice. The same with the Medicaid plans. But we here can give you pretty decent overview and pretty good advice about how to get into Medicare and how to get out of Medicare. So if we focus on that, if you find yourself transitioning into Medicare, maybe you're turning 65, or maybe you are about to start dialysis or about to receive a kidney transplant, there are a series of decisions that you're going to have to make. The first of which is, do you choose your Medicare coverage to be a Medicare Advantage plan, or do you choose Original Medicare? When you make this choice, you'll want to weigh a couple things. Medicare Advantage plans can sometimes offer vision or dental coverage that's not part of Original Medicare. On the flip side, what you give up when you choose a Medicare Advantage plan is you cannot add a supplement to an Advantage plan, and you elect some limited provider networks. You can see any doctor you want if you have Original Medicare. If you have a Medicare Advantage plan, you'll have to cooperate with the networks that are participating in that Advantage plan. So that's your first choice. Are you going to do Advantage or are you going to do Original? Neither choice is right or wrong. It just depends on what matches up with what your needs are. Now, if you choose Original Medicare, Part A is there for you because you're eligible for it, and it's complimentary as long as you've worked and paid into the tax system at least 40 quarters. So that's cumulative about 10 years. My high school days, I worked at a Dairy Queen for about 2 years. So there, 2 years of benefit. It doesn't matter. It doesn't have to be a fancy job. It just has to be paying taxes. So that time still counts to you. Part B is something you need to turn on. It has a premium of $134 per month in 2018. There's no flavor of Part B, either it's on or it's off. Part D, though, there are a lot of different flavors or plans to choose from. They can be as inexpensive as $10, $15 per month, or as expensive as $80 to $110 per month. In this domain, there's not a good plan or a bad plan, and each individual plan could be great or horrible for you, depending on how well it matches up with what your medication needs are and what your pharmacy preferences are. When it comes down to supplement, there's a document called Medicare and You 2018. It's a booklet that will walk you through everything you wanted and didn't want to know about Medicare. But in that document, there's a summary table that will compare and contrast the different supplements so that you can choose by supplement type and not get distracted or frustrated by all the marketing from the different companies. And then finally, there's this benefit called the low income subsidy, where the supplement plugs holes for what Medicare Parts A and B don't cover. The subsidy helps cap expenses through Part D. The subsidy is an income-based program. You have to ask to be screened for it. You can either do it in person at a Social Security office or online. It takes about 10 minutes to file an application, 2 weeks to a decision, and it could cap out your medication copays at $3 and something cents for generics, $7 and something cents for brands. So it's a massive benefit for those who qualify. Now, a couple of notes, especially for transplant recipients. If you were to generically ask Medicare, Part B, do you cover immune suppressants? They're going to say, yeah, of course we do. If you generically ask Medicare Part D plans, do you cover immune suppressants? They're going to say, of course we do. But the answer is, for you as an individual, only one of those two parties will pay for your meds, right? So the answer to that question lies is what was happening at the time of your transplant. If you had Medicare in place at the time of your transplant, then B is your payer. D, even though those drugs are on their formulary, when you try to submit a claim to them, they're going to say, nope, not qualified, submit the claim to B. So if you had Medicare at the time of your transplant, Part B is the correct payer for you. If you had any other insurance at the time of transplant and later turn 65, become disabled, go on dialysis, if at any time later you get Medicare, then D will pay for your meds. So when you're trying to choose a D plan, this website here on Medicare.gov, it says Find Health and Drug Plans. Through that link, you can plug in all of the medications that you need, the pharmacy that you want to use, and it will rank all of the plans that are available to you in order of least expensive to most expensive. But you will want to be very thoughtful about whether you include or exclude your immune suppressants, depending on if D is the correct or incorrect payer for you, because that factor can change the plan ranking pretty substantially. This website can both help you understand your costs if you're picking a D plan, as well as if you're picking a Medicare Advantage plan. This is a snapshot. I know you can't read it, but it's a snapshot of the report that you'll get after you finish the worksheet through that Medicare.gov website. And if we zoom in to the medication page, you'll see that the copays for the medications change throughout the course of the year. When you first get your plan, you might pay a deductible. After you meet your deductible, you'll be in this phase called the initial coverage level, and you'll pay that copay until you've spent a certain threshold of value. It's around $2,400 worth of drug benefit. Once you've spent that much benefit, then you move into the donut hole or the coverage gap. A lot of people are afraid of the coverage gap because you've heard horror stories from years past. The gap today is not as bad as the gap was 5 years ago. And look at this example. For the first 4 meds on this list, the copay in the coverage gap is actually lower than it was during the initial coverage. So the gap may or may not hurt. You have to run the reports to see what your specific situation will be. The last drug on this example, the valganciclovir, it's an expensive med. The $2,228, that's an average cash price. So the copay, and during initial coverage, you'd pay $891. In the gap, it would go up to $1136. And if you spent your way into catastrophic coverage, then it would drop to $111. It's usually at this moment when patients start to sweat and they're like, oh my God, this is awful. I will not be able to afford that. And so I want to remind everyone that when assembling your insurance mix, keep in mind it's kind of like laying bricks on a house, or cooking. You have to assemble all of your ingredients first. You can't start baking a cake until you have all of the ingredients. So don't panic just because you got the eggs out of the fridge. You need to get everything together, right? So this might be the reality. This might be as good as it gets through the insurance plan, but there are other options you can add on later, not through insurance, but through other assistance programs to plug the holes and to get access to all of the meds that you'll need. Briefly, with regard to Medicare supplements, a lot of different companies offer these supplements. Not all supplements are created equal, and they're named by a letter. So you can see here on the left are all the holes in Medicare Part A or Part B coverage, and then across the top, all the different supplement types. So the company doesn't matter, whether it's Blue Cross Blue Shield, Physicians Mutual, whomever you may pick. What matters is the letter, the type of plan that you get. You can see that Plan F is the most comprehensive, usually comes also with the highest premium. So you'll want to compare and contrast what you want, what you need, versus what the premiums are. And choose all insurance vendors that offer these Medicare plans have to follow this same algorithm. So you can, that can help you understand what you're purchasing. In terms of the extra help or the Medicare subsidy, it's a very easy online application, again, that can cap out your medication copays. So if you were the person that was worried about that $1,100 copay for valganciclovir in the donut hole, if you qualify for this, the low-income subsidy, definition of qualify is somewhere in the neighborhood of a monthly income of $2,400 or less for a household of 2. So if your income is below that parameter, ask to be screened for this. Fill out the application, and your copay would be capped at $7.70. So there you go, problem solved. Now, for those who are, like in Dave's case, who had Medicare and are now seeking to transition out, you'll want to seek those other non-Medicare buckets. If you're employed, or maybe your spouse is employed, seek healthcare insurance through either your or your spouse's HR department. If you have low or limited income, seek the Medicaid options through your state. And if you have neither of those, seek the Medicare exchange, not Medicare, I'm sorry, the exchange options through the Affordable Care Act. There should be something out there that's available to you. Now, once you've assembled your insurance, we acknowledge that there may be holes. You might have insurance, but unaffordable copays. So that's where these other tricks come in. You want to understand your benefit well enough to make sure that you're using the most benefit that you can. For example, provider networks apply both to physicians and pharmacies. They may apply to labs. Make sure that you're using providers for each aspect of your healthcare that cooperate with your insurance. Consider referrals versus open access. If your insurance plan is an HMO, you might need a referral from your primary care doc for each piece of healthcare that you access. If your insurance is a PPO, for example, you can probably just see who you want to see without that extra level of red tape, so to say. Medication formulary, again, maybe there are some revisions that your doctors can make to cooperate with your insurance formulary and keep your expenses as low as possible. There may be moments when you need a med that's not on the formulary, and then you can appeal, file prior auths or formulary exception forms. There are arguments that can be made with the insurance companies. You want to understand, is it better for you to do 30-day supply or 90-day supplies, local pharmacies versus mail orders? So there are a couple of maneuvers you can make inside your insurance to make sure that your copays or expenses are minimized. And once you've gotten through that, if you still feel like the ends aren't meeting, talk with your transplant center social worker or financial advisor. They have a lot of tricks that they may be aware of through foundations or even through the institution itself, through charity care, to make sure that you get access to everything that you need. I have a closing series here about how to plug any holes that might remain with regard to affording meds. So discount programs, we'll start there. Discount programs are offered by pharmacies themselves. So it might be your pharmacy has a $4 drug list or a $5 drug list. Maybe your pharmacy or some pharmacy in your community offers free antibiotics. You just want to know about that so you can take advantage of it if you like. The Good RX program that Dave mentioned is an awesome benefit. It basically gives you access to discount codes. The people that I really recommend use this, obviously, are people who are uninsured, because this can get you access to some pretty good pharmaceutical rates. But also, if you have insurance, it's still worth putting your meds into this app to see. Occasionally, you'll find that not using your insurance and just using a discount code through the GoodRx can actually save you a decent amount of money. If your copays are based on percent of cost, that's a particular example of a time when you might actually be better served by not using your insurance and using these instead. One downside to using these discount programs through pharmacies, though, is any money that you spend on those copays, they're not going to count towards your deductible or your insurance, because they're not going to see it. Another category are these programs. There are 3 different types of programs offered by the drug manufacturers. On the right, these are vouchers, 30-day free trials, 14-day free trials. It's exactly that, a free trial period on the drug in question. The pro here is that it's immediate complimentary access to the drug. Anyone can use them. There's no restriction on who can use these vouchers. The con is that it's a short-term, one-time benefit. So this is not going to be a permanent solution for anyone, but it can be a save-the-day type thing if you find yourself without med, stuck between insurances, or if you find yourself needing to start a med immediately, but it'll take, say, 10 days for your mail order drug to arrive. So the vouchers are there for that specific niche. On the left, these are pictures of copay cards. So copay cards can be a little controversial in the insurance marketplace because they have how they divert costs, but how it feels for a patient, you can use a copay card if your insurance is a private, commercial, employer-based insurance. Your pharmacy would first bill your insurance and then bill your copay to the copay card as if this is a secondary payer. They cannot be applied with Medicare or Medicaid, and they cannot be used in the state of Massachusetts for drugs where a generic is available. So outside of those few caveats, a copay card is basically someone else is paying your copay for you. A third dimension of assistance that's offered by the pharmaceutical manufacturers are free drug assistance programs. They're often called patient assistance programs. So who might be the right user of that? Would be someone who's uninsured or what we call underinsured, where you have insurance but your copay is not affordable. So those would be drug-specific applications directly to the pharmaceutical manufacturer. If you meet their criteria, generally it's an insurance as well as an income criteria, then they would send you drug. No pharmacy, like no cards, they would send you drug to your home complimentary, generally 90-day supply at a time. There's another category that falls outside of the pharmacy-based discount cards and outside of the manufacturer assistance that are these copay grants. Years back, there were copay grants for immune suppression. There were copay grants for CMV treatment. Those big grants that used to be lifesavers for a lot of transplant recipients are no longer open because the funding had run out. But there still are some grants that may be really valuable to you. For example, if you need treatment for hepatitis C, there's a grant specific for hep C. If you need treatment for hyperparathyroidism, like say you need Sensipar, there's a grant specific for that. The way these work is you have to have insurance with a copay that's not affordable to you. So the pharmacy will bill your insurance first, and then they bill the copay to the grant, leaving you with no out-of-pocket expense, and you get the drug. So the Hep C grants, as you can see here, are $30,000. So even if your copay is $6,000, even if your copay is $10,000, the grant will make that transparent to you. This, I find, for me personally, this is my starting point if I need assistance for a specific drug and I'm not sure what assistance exists. So if you go to the Needy Meds website, hover the cursor over patient savings, and then you can see there's the first two options there are brand name or generic name drugs. If you click on there, it's basically a clearinghouse of assistance programs. It allows you to search by drug name, and it will give you a menu of what's available, whether it's a voucher program, a patient assistance program, a grant. It'll connect you with what's available by drug. So if you don't know where to start, this is where I always start. With that, I want to turn the mic over because we have finance specialists, so we'll see if you have any additional tips.
Okay, thanks both of you. I greatly appreciate the opportunity to come up here and talk because I think a lot of times financial coordinators are sort of overlooked. And in the transplant community, facilities are required to have a transplant financial coordinator or financial advocate, whatever we're called, financial counselor, basically somebody that's going to help you with insurance type stuff, but only for transplant. So, first off, I'm just going to start, I'm going to maybe kind of catch some things that you've gone over a little bit. But one of the things that we want to look at is when a patient is being referred for transplant originally, they should be meeting with a financial coordinator, not just a social worker. And a lot of hospitals don't have it in the budget, or they don't have approval to hire separate people, and that's an issue. So you've got a social worker that is trying to deal with financial issues, and that's not really their specialty. Just like I'm not going to say, oh yeah, I think you should be on this drug, who know, for mental illness or something. Yeah, not my specialty. So anyhow, we will meet with patients and their caregivers when they first come in, and we're really trying to focus on not just how to pay for transplant, but how to pay for everything lifelong and hit every bump in the road like you've experienced, David, so that you don't have that gap. I mean, you're very fortunate. It sounds like it's a kind of a 1-month thing, and knock on wood, everything goes smoothly so we don't run into any complications. But it's really important, and it's kind of sad, to be honest. I tell patients all the time, especially 24, 25-year-olds, they might be on their parents' insurance, or they might be on an Affordable Care Act plan. They may be graduating from college, going out to get their own job, and you have to sit there and say, I know your dream is to be an artist, but you're going to be getting a kidney transplant or liver transplant, whatever. You've got to have insurance always, and until our system changes, it's not an option to not have insurance. But we don't want to discourage you from doing your dream, but most people can't go out and just purchase individual plans that are really affordable. And the Affordable Care Act has made a pretty significant impact in a positive way for the transplant patient population, but we don't know what's going to happen with that. And so we can just say, always be prepared. So we usually will go over medication costs more than anything with regards to a post-transplant issue. And for those of you that are patients, please remember that Friday at 4:30 in the afternoon, when you call your coordinator or social worker or pharmacist and say, I just realized I've only got 1 pill left of Prograf or tacrolimus, whatever, and I don't have any money. Then we're like, you knew this at least 4 or 5 days ago, or a week or 2. I love that you said you kind of stockpile. You're probably not supposed to say that because you're supposed to follow, your physician's orders exactly. But please remember, call before it's the last day. That's my first tip, because the worst thing that can happen is you go in and truly can't pay for it, and there may be grants. I mean, the HealthWell Foundation, which you mentioned earlier, is a great resource, and people can apply for that, but it's not something that you're approved of in 5 minutes. It takes a day or 2 or 3. So if you've got 1 pill left, that's not going to help you. You can't go to Costco or Walmart or Walgreens or whatever, pharmacy and say, hey, I can't afford this. And some of those pharmacies have individual pharmacy assistance programs, but again, they're going to want to verify income. Are you a Medicare patient? Are you a Medicaid patient? Are you a commercial plan? Because those things do make a big difference. So you have to be kind of prepared on the front end to survive the back end. And then there are things that come up that you're not expecting after transplant. Kidney patients typically have Medicare for 3 years post-transplant, and then it's gone. We try and educate them, and I promise, I've been doing this so in my real life, this is actually what I do. And I tell patients every day, you are going to have Medicare for such and such amount of time after transplant. At that time, Medicare is going to go away unless you're also getting Medicare for a disability or you turn 65 and over. The other thing is you have to remember that we tell patients that, and then Friday afternoon, also meaning 3 years after, they're like, oh, nobody told me that. Oh, yes, we did. We are saying things like, really? This is a great program. We're not going to go into the political reasons as to why it ends after 3 years by any means, but there are an exact, opportunity for you to know when this plan is going to terminate, and you can go out and do something. Things come up where maybe you are too sick to go back to work. So instead of saying, all right, I can't go to work right now, I'm not going to have insurance, maybe you need to start applying for permanent disability if that's where you really feel like you're at. The other thing is there are a lot of grants that are affiliated just within your own hospital systems, within your own state that you may or may not know about that you can apply for. But if you don't ask, they don't exist. And if you ask on Friday night at 4:30 when everybody's trying to leave at 5, they're hopefully going to help you as much as they are able to, but there's no guarantee that that's going to work. So what we recommend is really the financial coordinators at the transplant center can help you with post stuff, and if they tell you they can't, you just keep hounding them and say, no, you've got to help me. No, they shouldn't. They should be there for you because our specialty is transplant. And it doesn't matter if you're a bone marrow recipient or a solid organ recipient. If you're a living donor and something comes up that's directly related to your donation, let us help you find those solutions because there really are. And I love that you brought up GoodRx from a pharmacy perspective. It's not a perfect science yet, but it definitely has been helpful. And there are plans that or medication that at one pharmacy may be $400, and in the pharmacy a block away it's $5. So it's really just kind of researching, and I never knew that until I started doing this, that why in the heck do pharmacies have different plans? Well, it's all related to federal government funding and whatnot that's available. But you can really reach out to people and ask them where I can go for help. The other thing is not everybody automatically qualifies for FMLA, or there's COBRA. If you lose a job unexpectedly, or if a spouse passes away and they were the insurance policy holder, you can call that financial coordinator and say, hey, what can I do? This is my situation. And it might be a horrible thing to have to listen to. We had a patient recently, a lung transplant recipient that I was working with, whose spouse passed away in a really horrible auto accident, and he was the carrier of the insurance policy, and because of a lawsuit related to the accident, they were in limbo. So the insurance company didn't want to pay for anything. So she's like, I'm on Valsite, and at that time, Valganciclovir, there was no generic. It was just straight up brand Valsite, and she's paying something like $8,000 a month for this medication, and she's not under income to qualify for some sort of state grant, and she's not rich enough to just pay for it herself. So we have to find these kind of hidden tools that are out there, but you really have to do some research and find them to just make sure. Eventually, we were able to get her medications to her, and she's moved on and whatnot. But it's really challenging to have to say, hey, I'm broke. There are also things like, I'm paying $250 a month for my medications. My car breaks down. If I don't get my car fixed, I can't go to work, and then I don't have a way to pay for these medications because I'm not going to have insurance. But how do I do this? And I mean, if you live, and I don't live in, New York, where there's subway systems everywhere, and if you live in New Jersey, you can hit a train and be over there. I live in Utah, where we see patients in Idaho, Montana, Nevada, Wyoming, Colorado. I mean, it's not like everybody lives in a massive city, and they can just run and do something. If you live 17 miles away and there's no public transportation, bicycles and walking can be a while. So there are ways that you can see if there are things, looking at your church groups or other social groups that you belong to. If you belong to something like the Elks Club or something like that, where you can go and say, hey, this is something that's come up. How, nobody wants to go out and ask for help. And real quickly before we end, there are 3 things I really want to focus on that I probably should have started with. when we meet with patients at the time of the referral for transplant, there are 3 organizations that we recommend to every single patient, at least at my facility. One, Children's Organ Transplant Association, or CODA, the National Foundation for Transplant, and Help Hope Live. These are 3 nonprofit organizations that are specializing in fundraising for transplant patients. A lot of people don't know about these, and you may not qualify, but basically, these are government overseeing entities that are making sure that if you are doing any fundraising for medical purposes, one, it's a verified transplant expense. So if you raise $70,000, you can't go buy a new, Toyota 4Runner or whatever it is that you want. It actually has to be related to transplant. But money is donated in under your name, and then if you have a transplant expense, you can go out and get reimbursed or send the bill directly to that organization, and they'll reimburse you. And those are fantastic things. But I mean, if you're a patient that's been transplanted, you can apply for, they have grants as well as fundraising options where you can, they have people that will help you with fundraising and set up fundraising goals and whatnot. And they also have actual grants. If you have to be, if you're in, I don't know, Albuquerque, New Mexico, and something happens and you've got to get an emergent trip to Los Angeles to see your physician and you can't afford a flight or a bus pass, you can go to these organizations and see if they can help you get there. There are a lot of things like that that exist that just people don't know about. So I would always recommend, and if you are a transplant patient, you can apply for the option to set up a fundraising account through one of these organizations anytime after transplant as well. It's just the funds have to be used for transplant-related expenses. So that's one thing that you said right at the beginning, David, was the fact that you're a patient first, and I love that because I think a lot of patients get really excited after transplant because they're finally feeling really great, and they forget you're still a patient. You've just given up one disease for another. So remember to take care of yourself as a patient, as a caregiver, as a parent. Parents, talk to your kids about what's going to happen when you're not around, because you're not going to be around forever to take care of these kids. And they have to grow up and get their own insurance at some point. So there are a lot of resources. You just reach out to your financial coordinator. A lot of people don't know who that financial coordinator is. Call your nurse coordinator or your social worker, whoever you work with at your transplant center, and say, is there somebody I can talk to about finances? Right. There are all sorts of little tidbits that people don't know about. I promise, last thing, open enrollment for Medicare Part D as in dog, and the Medicare Advantage plans change based on the county that you live in. So obviously from state to state, but also county to county. And the drugs that you're on right now, they may not be on the formulary next year. So always, every year, if you are on a Medicare plan for medications, always go back in Medicare.gov and actually input your medications, because what's good this year may not be the best plan next year, and you may save thousands of dollars next year by doing that. And what's good for your wife is not good for you. The end.
That's great advice.
Thanks.
Thank you, Michelle, for that. Thank you, Dave, for sharing your story. I know we have used our time. We'll be in the AST booth in case there are questions. I know we don't have time to take them now since we have another talk coming right behind. But we'll be in the AST booth and be able to handle any questions or further conversation you'd like to have there. So thank you.
Thank you.